Thanks to those of you who were came well on time, maybe a little bit early. Sorry if you heard us setting up and doing the technological checks on this end. So yeah, today we're welcoming you to this webinar on capacity strengthening in One Health. And I am really pleased to be joined today by some really great colleagues and interesting speakers. So firstly, I'll introduce myself. My name is Lian Thomas. I am a jointly appointed scientist at ILRI, at the International Livestock Research Institution in Nairobi, Kenya, which is where I'm joining you from today. And I have also hold a position at the University of Edinburgh, where I lecture on One Health and food systems. I am joined today by Basiru Bonfo, who is the director of Afrique One Aspire, and he's joining us from Ghana, and we'll be talking to you. You'll hear more about the Afrique One program. We also have my colleague Shauna Richards, who is another ILRI scientist who's working on the COHESA, the Capacitating One Health in East and Southern Africa project, and you'll really excited to hear more about that today. We'll also, I hope, a little bit later be joined by Emmanuel Akunga, who is the director, the epidemiologist at the National Public Health Institute here in Kenya. And so we look forward to Emmanuel joining us a little bit later. So the structure of the webinar today, we're first going to hear some presentations from each of our speakers. And if you'd like to raise any questions about the presentations from those speakers, please could you just pop those into the chat? Because after the 4 presentations, we're then going to be coming together as a panel. And in that panel, we have a few questions to put to each of the speakers, but we will also be taking the questions from the floor, and I hope also opening up, if possible, to anybody who would like to make some comments from the floor and on your experiences of capacity strengthening in One Health. As we start today, please, as other people have done, please pop into the chat a quick hello and let us know where you're joining us from today. It's really great to see the wide network of One Health practitioners across different countries and find out what you're all doing. So without further ado, I will kick us off with my short presentation, which is based on the experience of the OHRECA program. So as I've mentioned, my name is Lian Thomas, and I'm actually speaking today on behalf of all of my colleagues on the OHRECA program. So Bernard Bett, Delia Grace, Ashni Moodley, Christina Roselle, Florence Matua, Dishon Malloy, Nicholas Ngwili, Jeffrey Njenga, and Rose Manu. They're the key OHRECA team, but we've been lucky enough to have a huge number of graduate fellows that you'll hear about later, and partners throughout the program. So I'm going to give you a little bit of a background to the OHRECA program, as this is our closing out seminar, and then we're going to reflect back on how the OHRECA program has supported One Health capacity development through different levels of engagement, those with graduate students, in-work professionals, and our community-facing activities. So the OHRECA program, which is the One Health Research, Education and Outreach Centre in Africa, was established here at the International Livestock Research Institute with support from BMZ back in January 2020. So this was a really generous funding over the 6-year period, and it was focused around sort of developing policies and practices that are founded on a One Health framework for preventing and controlling zoonoses, so both neglected and emerging zoonotic diseases, foodborne infections, and antimicrobial resistance. Of course, It's focused on sub-Saharan Africa, but I'll show you a map in a moment about the countries in which we've been working. And really, we're working towards a vision of healthier people, animals, and environment through a capacitated workforce. And I'll show you a bit in a moment about how that capacity strengthening was integral to our work. Here are our countries of focus. So we had 3 different work packs. One was on collecting evidence that counts. So this was really looking at our challenge focuses, so those neglected and emerging infectious diseases, food safety and AMR. And so we had a work package that really focused on the foundational evidence, one work package looking at the interventions, implementation and assessments of interventions, and the third work package which focused on partnerships and networks. And we had different areas of work across our key countries of interest. Those 3 work packages were based on an impact pathway where our end goal, as I mentioned, was that healthier humans, animals, and environments through sort of strengthened evidence-based policies and practices. And in order to generate evidence, in order to develop and test interventions, and in order to push partnerships and networks to allow the policy process to happen, all of this is really strongly underpinned by capacity development. And really, I think it's sort of worth just pausing and thinking, what do we mean by capacity development? And it's really the process of strengthening the abilities, the skills, the processes and resources that all of us, so that might be at an organizational level, at a community level, or at an individual level, all of us need to survive, adapt, and thrive in this ever-changing world. And we can think about capacity development within different domains. Of course, the most obvious one to think about is our educational system. So we're building their knowledge, critical thinking, and learning that enables people to go on and constantly improve, whether that's a student or institutions. And so when we think about capacity development at an educational level, we're considering things like curriculum development and fostering a community of lifelong learners. We then can think about capacity development within the workforce, and now we're sort of really focusing on the organizational capacities or leadership competencies, so that people who are in the workforce have the right competencies to do their job well and move forward into a more holistic, for us in One Health, move forward into a more holistic way of working. But we also really strongly believe that capacity development at the community level is incredibly important as well, because this enables communities who are the ones who are experiencing the One Health challenges that we're working on to be empowered to identify their own needs, to mobilize resources, and to implement the sustainable solutions that we might be able to bring them. And there are various, oh gosh, sorry. Don't know what happened there. There are various principles that are embedded into this, such as sort of ownership. Whoever the learner is, we want sort of strong ownership. We want sustainability, and we want inclusivity within our capacity development. And if we're thinking particularly from a One Health perspective, that capacity development needs to draw on frameworks and ways of thinking. And within the OHRECA program, we were very influenced by the work of the NEO group. So that's the Network for the Evaluation of One Health, both in the way that they created frameworks to look at the way that institutions work in a One Health manner, and also at a more individual level by the work they did on One Health core competencies. But we were also, because we're looking at challenge-focused areas, we're also looking at very sort of subject-specific competencies. So there are different frameworks we could draw on there. I just gave an example of the paper on core competencies for field epidemiologists as one example of that type of more subject-specific competency framework. So I mentioned that in the OHRECA program, we had various levels of capacity development, and I'm going to start with the sort of capacity strengthening for our graduate students by highlighting our OHRECA Graduate Fellow program. And this has been a really, really vital aspect of our work. And our graduate fellows have been the powerhouse of the OHRECA program in terms of being the frontline professionals developing and delivering really innovative One Health research. And through the OHRECA program, we were able to support 35 students from diverse geographies. So the majority of our students were from sub-Saharan Africa, but we also had Asian, European, and American students within our cohort. And we supported these students to be able to complete their PhDs or MSc studies with partner academic degree awarding institutions. Each student was affiliated to one of our challenge areas. So again, that was emerging or neglected zoonoses, food safety or AMR, and their research spanned all of our OHRECA countries. Their fellowships really provided an excellent opportunity to work with the subject matter experts, so the ILRI scientists and the university scientists and experts that they were affiliated with, to conduct really sort of cutting edge research and impact focused research. But while they also benefited from broader capacity development activities, both those here at ILRI through the ILRI Capacity Development Department, but also as part of the OHRECA cohort, which was coordinated by Nicholas and Gwillian Dishon Malloy. And that involved various seminars, trainings, and a sort of peer support network throughout their studies. We've got some photos here of some of our graduate fellows at the end of a training course. We have a photo down at the bottom of one of our fellows, Morris Karani, doing his field work in Machakos. He was awarded a prize from the UK Kennel Club for his work and has gone on to work for Mission Rabies in a really sort of impact-focused role. Many of our completed students have really gone on to embed themselves within government services or gone on to further study. So we have, a really sort of strong network here, and I hope that that network will continue to provide peer support to each other as they go through their professional career. The diagram at the bottom right here is followed the self-assessment of these students on their One Health core competencies based on the NEO framework. So we could use that to help identify the gaps that needed to be filled through the cohort. But as well as our graduate fellowship program, we were also able to support graduate capacities through wider networks. So some of those capacities were subject specific, and this work led by Delia Grace and Florence Matua supported benchmarks for the MSCs in food safety, which were taken up by the Inter-University Council for East Africa. So have a very broad applicability in the region. And this was incredibly important because we know that the burden of food safety in the region is incredibly high, but we actually at the point that this work started had a lack of any current of standardized programs to address this. So by creating these benchmarks for graduate training, the OHRECA program was able to have a long legacy outside of those cohort of students directly involved with our work. I mentioned the next level of capacity development that we were particularly interested in was that of workforce development. And one of the first activities that was undertaken under this program was using the NEO framework to evaluate some of the One Health workings in the different country level One Health units, and using that assessment, along with other stakeholder engagements, to identify training and capacity needs. And this led to ongoing workshops on a variety of different topics, particularly in our OHRECA countries. And if we look a bit more in detail at some of those training needs that were very much sort of demand driven, one of those includes support that was led by Bernard Bett on supporting East African governments to predict, prevent and prepare prevent, predict, prepare and respond to RVF. Obviously, Rift Valley fever, incredibly important, re-emerging zoonoses across this region. And so the sort of, as well as providing things like the decision support tools that allow better prediction of RVF outbreak, helping countries develop national contingency plans, there was also the need for sort of skill-specific training to underpin the ability of governments to actually respond in this way through stakeholder engagement and laboratory training and even in-field training. So there was a whole raft of capacity development that could support the tools that were being provided for governments. Similarly, and this was additionally work that was led by Bernard Bett as well as Christina Rosell, was participatory disease surveillance, so training animal health workers in identifying and reporting health threats in the field. Again, really providing that in-work training to strengthen the country's ability to prevent and respond to zoonoses. Another large sort of part of the OHRECA project was, as I mentioned, work package 2 on on interventions. A lot of these interventions, such as vaccination of dogs for rabies, require this underpinning of skills and competencies. And this work was very much led by myself, Maurice Karani, our PhD student, and Nicholas Bohr, who was one of our research associates, in partnership with Vétérinaires Sans Frontières Germany and Ezra Satote. And in order to allow for successful dog vaccination and correct response to dog bite incidents, you need a really strongly capacitated workforce. And so there was a lot of training that was focused at health practitioner level to really sort of sensitize the community and provide really strong ability to prevent and then respond to dog bites where necessary. And the third sort of strand of our capacity strengthening was that was community facing. And I'm going to highlight 2 projects here, one on which was focused very much at farmers, and one was focused at sort of dog owners and community members. And so the first one exemplifies a human-centered design approach to interventions. And this was the work from the AMR team, so led by Arshni Moodley and Dishon Malloy, who work with human behavior change specialists, 17 Triggers, to develop interventions which could support Kenyan poultry farmers to reduce antimicrobial use. And this really focused on a paradigm known as the elephant, the rider, and the path. And I'll just explain that briefly. It understands that we won't get behavior change without understanding our emotions. So the elephant, which is what we feel, our knowledge and awareness, so what we know, which is the rider, and the environment and the enabling environment around us, which was the path. And so this approach to human-centered design enables all of these aspects to be brought in together, and for farmers to sort of co-create the interventions or the nudges that would be most useful to them. And obviously through this process, the process of developing these interventions is a capacity strengthening process in itself. And it really ties together that idea that we need not just knowledge, but we do need to appreciate the underlying attitudes and that environment to be able to make sustainable change. And this work ended up selecting 14 different sort of nudges or triggers aimed at critical behavior change, and to rapidly test those to find the ones that worked best in the community. And that second example I said I'd use was thinking again back to the rabies work, where I mentioned before the need for a capacitated workforce to enable vaccines to be rolled out and dog bite injuries to be successfully dealt with. But actually, if the community themselves are not sensitized, aware of the risk, and capacitated to take and given agency to come forward and have their dogs vaccinated or to approach healthcare facilities, that undermines all of the rest of the work. And so here it's really about creating impactful community-facing communication tools. And in order to do that, we used a co-creative process, and you can find the paper on this that was published just a couple of weeks ago. And this was led by Jeffrey and Jenga, our communication specialist, along with Nicholas Bohr, one of our research associates, where communities sort of really were asked to look to the values that they attribute to their dogs and the values that they attribute to vaccination, and use a creative process to develop sensitization tools that really sort of spoke to them and to their values. And if you want to engage with more of our community-facing sensitization tools on rabies, please scan this QR code. We have videos, we have posters, and animated cartoons, which have really sort of been developed to, as I said, give community the agency that they need to protect themselves. So in conclusion, I know this has been a bit of a whistle-stop tour of some of the capacity strengthening that we've done under the OHRECA project, but I sort of just wanted to highlight that actually our research, particularly research to development that's very impact focused, is utterly dependent on the capacity of those who are going to conduct it, who are going to utilize it, or be impacted by it. And so if we want sustainable interventions, we really need to provide all those actors with the agency to lead change. And this is done through a huge amount of collaboration. So we need different disciplines, different sectors, different regions engaging with all these people, so that we have the sort of breadth of perspectives, the breadth of experience brought to students, frontline professionals, and community members to provide them with the appropriate tools to address the sort of complex challenges that we're dealing with. And so given that we've talked about partnerships being important and that breadth, I'd just like to say a huge thank you to many of the OHRECA partners and collaborators. I've probably even forgotten some on here, so apologies to those I have. And I will stop now so that we can pass on to our next speaker. So I will stop sharing. Thank you very much for your attention. And I am going to pass to Shauna Richards next for her presentation. Thank you.
Thanks, Leanne. Let me just share my screen. And can you just confirm that you're seeing my screen?
Yes, perfect. Thanks, Shauna.
Thanks so much for inviting me to talk here today. And like Leanne had mentioned about the OHRECA project, I'm speaking on behalf of another large team for the Cohesive project, Capacitating One Health in Eastern and Southern Africa. Too many names to even list. There's over 50 of us, but just know that I'm just one of the many team members that's sharing some of the work that all of us have contributed to here today. So just to set the scene about the project that we're working on, So Capacitating One Health in Eastern and Southern Africa is a 4-year project about building society-wide inclusive systems to rapidly manage and resolve One Health threats. And so we do that with partner organizations in 12 countries across Eastern and Southern Africa. These are universities with expertise in One Health. And so they implement the project in all of their own respective countries. And they implement across 4 thematic areas, which is knowledge sharing, improving One Health governance at the national and subnational level, education and research, which is what I'm going to talk about today, about building the future One Health workforce, mainly at secondary and tertiary education institutes, and then also delivering One Health solutions. So what I'm going to talk about in today's presentation is a bit about understanding the current landscape of One Health education in Eastern and Southern Africa, with a focus on higher education, with a little bit of results from a research initiative we did as part of the project. And then I'm going to talk about some of the initiatives that COHESA has implemented to fill gaps and advance the future One Health workforce at higher and lower education levels, as well as in-service capacity development. So the first thing I mentioned that I'm going to talk about is a bit of research. And so if you want to read the whole paper, you can scan the QR code. But essentially, it's about building the future One Health workforce in Eastern and Southern Africa, looking for gaps and opportunities in higher education. So this publication is just focused on tertiary. So we know that we need to capacitate One Health workforce to tackle One Health issues, and there's high-level buy-in from OLEP and the quadripartite, but there's not consistent ways to implement One Health education to ensure that we have a competent workforce regionally and internationally. So we wanted to understand what was available in One Health education in Eastern and Southern Africa, and also to understand what competencies they felt were important for this region, recognizing that there is research, obviously, on the One Health competencies that are necessary, but we wanted to make sure that they were reflecting the competencies necessary within the Eastern and Southern Africa region. So I'm not going to go into detail of the methods, but essentially we did a questionnaire to ask people from different academic institutes about One Health education in the Eastern and Southern African region. And we were able to find a total of 166 educational interventions. And so most of those were courses meaning they contribute to a degree program, and 35 were programs. And of those programs, most of them were master's programs, so ending in a master's degree. And we're even able to find an additional 14 educational interventions for a total of 180 after some validation. So there's a lot of One Health education happening in Eastern and Southern Africa, and we know this list is not exhaustive for all of the higher education institutes in the region, but gives you an idea that it's pretty busy. When we asked people about what competencies were essential, we found that more than 60% of respondents thought more than 10 technical competencies were essential to work in One Health, and these span animal, human, and environmental technical competencies. And they also thought that you needed more than 20 cross-cutting competencies. So quite a lot of competencies, and I'll talk a bit about what that means. So just to give a bit of an overview of our main findings, we found that awareness of One Health education at higher education institutes is quite limited, not only within the country, but even within a university. Many faculties aren't aware of what the other faculty is doing within One Health. This is obviously going to be a challenge if we're wanting to have good One Health comprehensive education, if people aren't aware of what's going on and not sharing resources. We also know that there's not a catalog on offer to identify programs or courses, or even kind of within the region what's happening at higher education institutes. So that's a challenge. We know that there's no way a degree program of any type is going to fit 10 technical and 20 cross-cutting competencies. Nobody can be an expert in everything. And what we often found was that respondents say what's essential is based on their own area of technical background, but aren't really thinking about how One Health is people coming from many different technical backgrounds and needing cross-cutting competencies to work together. So we know that silos are remaining. There's a lot of compartmentalized ways that One Health is being implemented. There's a lack of awareness about what is happening in One Health education, leading to duplication and people not being aware of other ongoing initiatives. There's a lot of work being done, but it's not necessarily building on past initiatives or country priorities. And we know the environmental sector tends to be left out. One Health is a really diverse area with many disciplines and expertise, but we need all these disciplines to come together with cross-cutting competencies to be able to work together with one another. So these were some of the challenges, and now I'm going to talk about how we work to address some of those challenges. So we had to come up with a plan, And the way that we came up with a plan in countries was each country used data that we collected from that first study. So the first QR code is about higher education and what's on offer for One Health, what I just mentioned. But countries also did a baseline assessment of One Health in their countries, which is the second QR code if you're interested to look. We have a case series of all the 12 countries we worked with, and one of the things they looked at was education in addition to the other thematic areas of the project. So we used these to plan how we were going to address some of those gaps. So one of the first things that we did to manage one of the gaps in terms of having standards for a One Health education would look like, recognizing that that was one of the most common programs. And like Leanne had mentioned, we already had a working relationship with the Inter-University Council for East Africa, which sets standards for education in the Eastern African region. But recognizing we were working with broader stakeholders for our project, we also brought in representatives from Southern Africa and Ethiopia, who's not part of the Eastern African community, to contribute to these benchmarks. So they really reflect the Eastern and Southern African region quite well. So these benchmarks help to standardize what a master's in One Health should look like, but even more broadly, what competencies are needed for any One Health education program, because they really focus on cross-cutting competencies and basic understanding of core competencies of the core kind of thematic areas of One Health. And there's options for things like elective courses within this set of benchmarks to cover different technical areas. And we also know if somebody comes to a master's program, they're already going to have an area of technical expertise from their undergraduate degree. So it really helps to ensure that anybody who wants to do a master's in One Health, whether they're vets, medics, they're environmental health or social sciences, these benchmarks can apply to any of them, and the QR code can help you access those. They're freely available. Some of the things we did at higher education, we again have quite a few things that have happened, and I'm just mentioning a few. If you scan the QR code in the top, it goes to our website, the One Health Observatory, where you can filter by education initiatives to see some of the things that have been done and access some of the resources or contact points. But we worked on things nationally and subnationally within countries within higher education, so tertiary institutes. And for example, at the national level, Ethiopia worked to develop One Health education and research guidelines that are implemented at the national level. And then they work to train 270 faculty members and 8 universities to cascade down these guidelines so that consistency in how One Health education is being implemented within Ethiopia, for example. Malawi developed a One Health University triad between the 3 major universities with representing One Health sectors in Malawi to have symposiums and work together on shared One Health initiatives. So this has been a great way for people to avoid duplicating their work and actually work together. At the subnational level, we have things like the University of Nairobi working across the university to ensure that faculties are working together. As I mentioned, many faculties aren't necessarily aware of a cohesive One Health approach within the university. So the University of Nairobi is working to address that, to have a more consistent approach to One Health and sharing resources. And Rwanda has a really unique initiative where they're doing multidisciplinary hands-on One Health training so that students come from different disciplines and sectors within not only one university, but sometimes multiple universities to learn together to address One Health issues that are happening in Rwanda. And so by doing education that brings together people from different sectors in an academic setting, it's much more likely that they're going to be able to apply these skills in real life when they need to work together across different government ministries and different sectors when they're out in practice. We also did quite a bit of work in continuing professional development because we know that a lot of people who are out in the field, it would benefit them to have One Health education. So 2 areas that I really want to highlight that we work to capacitate people on in our project, but I think are relevant for anybody, is one is the Workforce Development Operational Tool, which was developed by the World Health Organization and the Quadripartite. And part of the Workforce Development Operational Tool, which is to address competency gaps in One Health, mainly related to zoonoses, but also cross-cutting competencies that are useful in any One Health area. This Workforce Development Operational Tool has a database of more than 400 trainings and many resources and help fill competency gaps in One Health, specifically in working professionals. And so this is the largest database that's validated with good access to online training and in some cases in-person trainings that are available for from an international perspective. So we trained countries as part of the Cohesive project to use this database so that they could capacitate their workforce, but also think about how they could use those resources to develop materials within an academic setting. So instead of reinventing the wheel, they're able to use available resources to help develop their course materials. Similar to this, as the project, we developed a global One Health search tool, a GHOST tool, and the link was for the observatory earlier, but I'm sure I can share many of these afterwards. But the difference between the workforce development tool and our tool is that ours is mainly for an individual looking to fill gaps. They're able to find online free or paid resources that they can take trainings to fill some of the gaps that they think they need to fill themselves. Some of the few other capacity development projects that we did, we work in communities. In one example, in Namibia, to capacitate people around food and food security and food production with One Health approaches. So bringing together multiple disciplines to have a community trained and capacitated and how they can improve food production and food security. We've worked to train faculty members to integrate technology and cross-cutting competencies into how they're teaching. And so this was really important because faculty members who are teaching at higher education institutes require the skills to be able to think about how they can integrate cross-cutting competencies into their current curriculums without changing the curriculum, and also integrate the use of technology to better serve the students that they're teaching. We've worked to capacitate young researchers to improve their ways that they can do laboratory and applied field research in One Health so that they're the future leaders. And we have examples of online courses and food safety and One Health approaches that have also happened. So a lot in the capacity development sector. And I just want to take a moment to mention about lower education, which is at primary and secondary levels. And while this wasn't a major focus of the project, the countries we worked with felt it was really important to try to capacitate students at lower levels of education. And the reason that they thought about this was because when we try to integrate One Health at lower education levels, it's really ensuring that students have this understanding of the One Health concepts and approaches from an earlier level, which will really help to transform society's way of thinking about One Health as they continue to move through the different education levels within their countries. So some of the things that we've done to try and address integrating One Health at lower levels of education was really successful in Zimbabwe, where they're integrating One Health modules into their teacher training curriculum. And so that means all of the teachers who are going to graduate from teacher college understand One Health approaches and how they can integrate One Health into existing curriculums that they teach in real life. Because oftentimes it's not about changing the curriculum, but it's reframing how you're teaching current topics within the curriculum that you're already teaching. And so within other countries like Kenya and Somalia, we've done work with train the trainer approach of primary and secondary level teachers so that it can cascade down to how they teach students. And again, we're not trying to necessarily change the curriculum, which is very challenging, but reframe some of the existing curriculum so that it's better contextualized in terms of One Health and linking some of the different topics and subjects that they're learning within school. And so we also had similar initiatives in Tanzania and Uganda. And so it was quite a popular initiative to try and integrate at lower levels of education. So I just want to end about summarizing an approach for One Health education that I think we can report from the Cohesive project. I think it's really important to start to know where you're starting, to understand where things are within countries or within the stakeholders that you're working with to plan a way forward. This doesn't mean you need to do a study to understand what's happening, but you can use available resources to know what the current situation is and talking to people to make sure you're not going to be duplicating something that's already there and using the available resources, and also making sure that you're filling the gaps that are identified by the stakeholders that you're potentially going to do a One Health education initiative. So this first QR code goes to the Workforce Development Operational Tool by the WHO, which has that huge database of available trainings, tools, and resources related to One Health competency gaps. I already shared with you that there's the Global One Health Search Tool for the Cohesive Project on our One Health Observatory website, where you can look at available education, as well as some of our baseline work. So it's nice to know where you're starting so you know where to plan the way forward. This is really important to avoid duplication, but also to have some consistency. We know there's consistency between education if you think about what's available for vets, what's available for medics, for example, but it's not necessarily happening within One Health education. So having the Inter-University Council for East Africa One Health Masters benchmarks, a really good place to start. not just if you're having a master's program, but more broadly. And I'd also like to highlight, like Liam had mentioned, the NEO core competencies as being another really good place to look at, which is the second QR code for those cross-cutting competencies, which are so important that everybody needs if they're working in One Health. We all need those technical expertise, but if we don't have the cross-cutting competencies to work with one another, it's going to be very challenging to operationalize the workforce. And finally, focusing on train the trainer and innovative multidisciplinary teaching, I think is a really good way to have One Health education move forward, because without having students learning in cross-disciplinary and multi-sectoral environments, it's really going to be hard for them to then do that in real life. So I'll end there and just say thank you to all of our partner organizations within the countries that we work in, our consortium, which helps oversee the project, and our funder, which is the part of the EU. So thanks so much, and I'll pass it back to you, Liam.
That's really lovely. Thank you so much, Shauna, for that whiz through what the COHESA has been doing in this space. And I've certainly got some questions to come back to you with in the panel later. I'd now like to ask Professor Bassero-Bonfo, who's the chair of the advisory committee for OHRECA, as well as being the director for Afrique One Aspire, to tell us about what Afrique One has been doing in this space. We've been there for a long time, and I apologize to you, Bassero. For some reason, I picked you up from Senegal and put you in Ghana earlier, so I apologize for that. But thank you so much for joining us here today, and I'm really looking forward to your presentation on Afrique One Aspire.
Yeah,
Over
thank
to
you very much. Do you hear me?
I do indeed. Thank you,
Yeah,
and see you.
thank you very much. And it's always a pleasure to work with you people at ILRI, with OHRECA. And I'm very happy to share the experience, which also span from West Africa to East Africa, and showing also what we are doing in the Francophone zone. I will stop my camera because the connection may be very challenging. So I have been asked to talk about capacity building, and here we want to present what we call the Afrique One's model for workforce development and research in capacity. And just to go back to the content, sorry, let me see. Yes, so I will just tell you about Afrique One and what is the model we are using and some of the impact, and coming with the challenges and some of the lessons that can help for future activities. So in 2008, we were working on a program called Livestock for Life, and it was funded by the Wellcome Trust. And during that time, there was a call on African Institutions Initiative. And that call was to ask African leaders to propose a capacity building program in Africa. So by that time, we said, okay, we were working on zoonotic diseases and some of the cross-cutting issues, and we found that the collaboration and coordination of collective action with some of the complex health issues were a big challenge. So what we proposed by that time is to develop a program that we call Afrique One, and that program will strengthen the capacity of people, institutions, and countries to be better prepared for some of the health threat, because by that time we found that none of us had a competence to address those cross-cutting issues. And we think that we need a new generation of people to work collaboratively and to address those challenges. This is where we came from. And our focus was, as we said, to look at the resilience of our people, institutions. And later we said it was very important to go beyond zoonotic diseases, because sometimes when we talk about One Health, many people think that it's only zoonotic diseases or aspect at the human-animal environment interface. But our focus in this training was to take this third pillar of the public health, which is for us the health promotion. How can we do to anticipate that disease emerge instead of just responding? So this is where we have built Africa One. You can see the institutions, the partner institution, including ILRI, that have been very instrumental when we were working on the lab with Baker lab in ILRI, and the collaboration was very strong, and still we are working together. So this is the current cohort of Africa One that we have launched 2 years ago in Tanzania, with 62 fellows from masters to PhD. So if you look at the program, we talk about the capacity building in One Health. It's need a long-term program. And it's only now, since 2007, when we were working on Livestock for Life, then after with the Wellcome Trust funding, and then we Aspire, and now with Africa One Reach, with Delta Africa, we have seen that doing things in the long term, not just short term, really bring good results. And this is why now we have, with the current program, expanded our focus not only on the diseases aspect, but also looking at how the transdisciplinarity can be used, how the local knowledge can be used to transform the knowledge, and how can we model intervention to show the added value of this collaboration and to move to the decision making. So our structure is very aligned to our institutions. Africa One doesn't stand alone, but we are embedded in our partners' institutions, and we have a capacity building component, and the funding flow also follow what we call the hub and spoke models. We have the hub at Centre Suisse, the Recherche Scientifique, and we have partners in different countries, and those partners support the graduates and the practitioners. So we have what we call the stepwise approach whenever we recruit fellows. When I talk about the graduate, we have what we call the first stage was the innovation, which is the research component. And in that research component, we have masters, PhD, postdocs, and we also include practitioners because we have a very specific training for them. Then we have a second component during the course of their training on the knowledge transformation. How can they test intervention using different models, small funding that we provide to them to validate, to test and validate their research. And the last component is when they reach at the end is to evaluate the impact. And sometimes when we show the impact, it does not mean that decision makers will take decision. We have to show with some of the tools, like for example, the game theory, to show that investing in One Health intervention can yield an added value, which is very important. So those are the three big components. So the target area, I think, Lillian, you mentioned that we have 8 main focus target area for capacity building. But for us, skills, infrastructure, resources, and institutional frameworks are very, very important. I think Coesa also mentioned that. We sometimes as technicians, we know what to do, but when time comes for collaboration, this is where we found ethical problem, we find legal framework problem, and those kind of capacity are very important to consider. So in Africa One, what we do, as I said, we focus on individual. We look at the critical mass of practitioners in their countries, like in the One Health platform, and we also target institutions where we work with them to see in which area we can upgrade some of the aspects that can help to do the work, for example, the lab equipment and the tools. And in the community also, we have a very big component on the engagement. And one thing we have introduced the last couple of years is to work with communication specialists. And we have supported one of our former fellows to create what we call the African Science Communication Agency, helping also to bring the debate in the media area, and we support conferences, and we have now started what we call the Science Journalism Academy, where every year we will support 12 young students who will come and report on One Health activities. And one last thing we have done is to support one of the country, Cote d'Ivoire, to develop their national public health bulletin, which take into account all research, all interventions on One Health, and we intend to multiply that in some of our partner countries. So what is very important for us is the continuous training need assessment. You know, we can build the list of competencies, but when the time change, the competence, the need change. And this is what we have been doing since 2009, where we have started with 4, 5 competencies. Now we are up to 30 competencies that we provide to the fellows. And these things have been put into all our training program, including the massive open online course that we have developed since 2016, which is widely used by the whole community. And one point that on which I want also to emphasize is the capacity of people in their institution to collaborate. The collaboration is key. Knowing a zoonotic disease is not the problem. Each sector has a key to the solution, but the key issue is the collaboration. How can we train people to have a very good system thinking, targeting the complex issues and collaborating to gain another value? So those are the aspects that are very important. Then we have the coordination. If you have many sectors, many people working together, we need a very good leadership for coordination. So the training and leadership in health system is something we have identified as very important. So I have already talked about the hub and spoke model. With that, what are the impact? First of all, as I told you with our model, we have looked at the fellows we have trained, and looking also the area where we don't have the capacity to change things. In the theory of change, we call it the influence zone. And this influence zone, we make our fellows aware that there are issues that they cannot move forward if they don't have a very good institutional environment. So in this evaluation, we consider that, and that the last one is the impact and the added value. So far, if we sum up the fellows we have trained, the graduates, up to now we have 225 graduates under a postgraduate. And if you see the evolution with the number of countries, the number of institutions, and the fellows, and you will see that I mentioned that we have recruited 62 for this cohort, and we will see that we have up to 91. Why? Because we have decided now, instead of just organizing our own training, to support institutions to set up their master courses where they bring the One Health experience in that. And most of our fellows are going to retain in the academia, in the research institution, and most of them are now at the international organization, and very few are in the countries, and this we need to think very carefully where they go. But we said it's very important to train fellows, but strengthen the capacity of those who are working in the countries are the area to move. And you see in this map, our concentration countries are Cote d'Ivoire and Tanzania on the distribution of the fellows. And here is the course session that we organized. We have improved the number of sessions. And in this training, we found that session more than 10 days training are the one full light, because training people on 1 day or 2 days in One Health is very, very limited. So it's important that we take more time for them and to use the principle, test the principle, and have the field exercise. And we found that with this 10 days to 2 weeks training, the model that are very important, and this is what most of the fellows like. And we have also looked at how they use the One Health. What we call One Health here is all the principles, but most of them don't use the One Health approach as such, but they just take aspects that are important for them. For example, the transdisciplinarity aspect, the collaboration aspect, to improve the quality of their work, and to improve also the efficiency of the work. So sometimes when we give the One Health training, it's not that they will go and apply everything. They will just wait and take pieces that may need to fix their situation. But what was very important is that now, with most of our fellows, they are now training others, which is a multiplying effect. And I was just talking about the change in the model. Instead of having programmatic graduate training, we are now adding master courses. We are not creating One Health master courses, but we bring the One Health approach into the master topics. For example, in Benin, we have a master on risk analysis, and we put the One Health on top of that to see how fellows can be trained using the One Health approach in risk analysis. The same thing at University of Liège, and we see in Togo also we have those master courses, and this is what we are now developing. Another aspect in which we provide support is the policy engagement, because we put our fellows, we expose them to the regional, national, and international debate on their topic. For example, with WHO, we have been able with the skin NTD to push for the change in the policy. In West Africa, we have developed, thanks to the postdoc, the regional One Health coordination mechanism and the policy on food safety in Cote d'Ivoire. And this is one of the example of our fellow at WHO explaining the work on skin disease as a global public health priority, which is now endorsed. And our fellows have also contributed for the last couple of weeks to map the risk of avian influenza in West Africa, in the 15 West African countries. That has led now to the regional strategy for avian influenza control. And the paper we also mentioned with Kabi, and was on how we have tried to build the One Health coordination mechanism for the 15 countries in West Africa, which is now used to develop the West African policy on One Health approach. So what are the challenges? I hope I have not taken too time. The challenges that we have high demand from people, from fellows for the training. And it's very important to have resources for that. We have the rigid academic silos. We don't want to transform, as others said, curricula, but just to integrate, for example, system thinking and transdisciplinarity in the current training. That will make a big change. And sometimes when we put our fellows and they address a One Health topic, it does not match with the academic disciplines, and sometimes we face very big challenges. And if you see in the map at the right side, we need also to think or to uh, learn how to work in the insecurity zones. It's also part of the complexity of the One Health approach. So the lesson is that today One Health is used everywhere. What is One Health? What is not One Health? But we said that the training we provide just help contribute to fix to a problem. It's not an approach to solve all kind of problem. And it has to be deductive or inductive. You can start a One Health program and prove that you have had a added value, or you start a program without calling it One Health, and at the end of the day you see that you have used the One Health approach, which help to be more cost effective. The system thinking is something we should address and call people to look at the complex health problem that One Health can address. And the long-term funding in One Health research is key, because whenever you have a result, it's another problem, challenge you face. So it's very important to test a long-term programmative area. And then the last point, as I mentioned before, we have to learn to know more about the influence zone, how politics work, how communities work, because sometimes our findings are very good, but putting that in the context is another thing. The decision doesn't depend on we researchers or practitioners, but it depends on whoever make decisions. So the decision-making process and the legal framework aspect are very important. And we have also seen how health aspects are scattered in different ministries in our countries, making the collaboration and the coordination very difficult. So I would like also to thank our funders and the partners and collaborators, and thanks also to OHRECA for this nice journey. I really appreciate, and I'm very grateful to all the management staff of ILRI and OHRECA for putting me in this wonderful network. Thank you very much.
That's really wonderful. Thank you so much, Basiru. And it is really wonderful to hear from a project that's got such, just such a long experience. It's sort of coming up for, well, almost 2008. So we're, 17 odd years.
Yeah,
of experience there, and what a journey. And One Health, of course, has changed so much in the time that you've been running AFRIC1. So thank you so much, and it's great to have you here. I'm wondering if Shauna and Basiru could share your cameras again. Let's see how the network does. Of course, if it fails, switch off. Jeffrey, possibility of trying to pin us so that we can see everybody. We'll now move to a bit more of an open panel discussion. I've got some questions for Shauna and Basiru, and then please, if people could put things in the chat, I might then pass to my colleague Nicholas Ngwili to ask the whole panel some questions from the chat. It's a bit more difficult to find things in there. So I'm going to start. I think it's just with a bit of a reflection on the presentations, and I think it's really interesting that we've got heard about 3 different projects, and each of them have really sort of used this multi-level model for capacity strengthening. So, at the graduate level seems to have been a huge focus for all of us, but also thinking about the professionals and institutions and the community levels. And it's great to see that reflected across all 3 of the projects. We've heard a lot about the general ways that we approach capacity strengthening. So I want to go a little bit deeper into some of the specifics. And Basiru, you mentioned that the sort of technical knowledge, like say the technical know-how on zoonotic diseases and things, wasn't lacking, but collaboration and systems thinking were the sort of key gaps. So I'd love to hear a little bit more about some of that training that you've been doing that focuses on the collaborative side of One Health and the systems thinking side. And then maybe I'll go to you next, Shauna, to get some of your reflections from COHESA on that. So over to you, Basiru.
Yeah, thank you very much for this nice question. If I take, for example, Rift Valley fever for the last decade, you ask a vet, the veterinarian will know what is Rift Valley fever, but the medic sometimes don't even address that in their reports. And if you go to the environment sector, they can have very good climate data, but they will not link that to vector emergence and up to the disease. So each of them have the knowledge. But the moment you have, for example, the Rift Valley fever outbreak, or set this as a priority, then you have to bring all those, we need an entity to bring those three components as the starting point, where the vet will explain the epidemiology of the work. And sometimes if the medic does not have knowledge on Rift Valley fever, this can be sometimes a very targeted training. And then when you put all of them together, they can have a common understanding technically what is Rift Valley fever. Then the second step is that, okay, they have this, what we call the system knowledge, this academic knowledge. So when they go to the community, what is happening? So they need to know what community thinks about the disease. And this is where we need, for example, social sciences, techniques to mobilize the knowledge. And at the end, you need economics to look, okay, what is the impact and how we can reduce the cost. So this is the type of mechanism we need, which take a lot of time in bringing people together, sharing knowledge and sharing resources. Because we don't want the vet to know what is happening in human. We don't want the medic to know what is happening in the animal sector. So we want them to be aware about where the disease is coming from and how together we can control it. So I just took this example of Rift Valley fever because we have that in our face in Senegal currently, which is coming because it's not that we don't have the knowledge is there, but it's scattered. But doing joint surveillance, collaborating was the key missing link that unfortunately made many people to die out of the disease.
Thanks, Basiru, and I'm sorry to hear that there was, you've had a bad outbreak with fatalities, but it's great to know that through the practical aspect of coming together to deal with an outbreak, people were able to learn more and collaborate and bring that knowledge together. So I took a lot from that you're sort of very keen that it's not about making sure, as you say, a vet knows the human side of things, but knows who to go to, how to talk the same language, and how to move together to bring that knowledge to bear. That's excellent. Thank you so much. Shauna, I'd like to know from you, first, if you can reflect specifically on anything around collaboration and systems thinking that COHESA has been dealing with, or maybe there's some other sort of One Health core competencies that you focused on that you'd like to highlight. Thank you.
Thanks. Yeah, I think just as Basiru mentioned, these cross-cutting competencies, which include systems thinking, policy, communication. These are the competencies that we've been focusing on a lot. And I think it's been challenging because not all of our technical experts were not pedagogical experts. And so thinking about how to integrate learning cross-cutting competence has been challenging. And what I can say is that what we learned from experts from the University of Pretoria who are experts in pedagogy and One Health is that they taught us about, it's not necessarily what you're teaching, but it's how you're teaching, which will help integrate cross-cutting competencies. So the technical competencies, like Basiru mentioned, those are strong, and it's important that people understand the relevant aspects in the different sectors and disciplines. But it's about how you're going to teach them anything that you're teaching within their technical areas that will help them develop these cross-cutting competencies. And a good example of one was the one I mentioned about Rwanda, where you're bringing people from different sectors and disciplines in an academic setting where they're still learning to actually work with one another to address One Health challenges that are happening in Rwanda. And so by bringing those people together, you're developing their cross-cutting competencies without necessarily teaching them in the same way that you teach how a disease is spread, which we all know, we talk about that in a very specific didactic way. But these cross-cutting competencies are a lot more about how you design how you teach and how you're doing your teaching than the actual content that you're teaching. Because you don't stand at the front of the room and teach people, specific things necessarily about systems thinking or policy or communication. And some of those are you can talk about to some extent, but you really learn them by doing them.
Yeah, absolutely. I mean, I think I take from both of your examples there that actually it is the practical aspect of coming together, either coming together to learn through doing in a more classroom-based setting, or coming together and learn through doing, in an outbreak setting, but being supported to actually make sure that those are teams, multi-sectoral, multidisciplinary teams. So yeah, I mean, I would agree from a sort of pedagogical point of view that there are these competencies that have to be woven into a curriculum through the exercises that you're doing rather than a didactic approach. So that's really, really interesting. I think, Basiru, I'm going to come back to you because you mentioned specifically how, and actually it's quite an interesting difference. I see that COHESA has developed the One Health Masters benchmarks, and I'll come to you in a moment, Shauna, about some of the actual One Health programs that are spinning off from that. But Basiru, you mentioned specifically that you didn't necessarily want to have a One Health specific masters, but you were integrating One Health competencies in the existing masters programs. So building on what we've just talked about of the difficulty of doing that, and it very much being around the way that these competencies are taught, I'd love to hear about maybe how some of those master's programs are bringing these core competencies on board. Thank you.
Okay. Yeah, I will take the one that from my country, Togo, University of Kara, where they have a master course on, they call it food security and nutrition. And they invited me to give a lecture on food security system, and something for an introduction. And when I came, I raised the fact that nutrition is at the center, and affected. If we put the nutrition in the system, you see that climate and agricultural systems are very important. Then nutrition depends on culture, and nutrition can shape the health of people. So when you take this pathway from climate up to the well-being of people, you need many disciplines, and each discipline or each sector can bring contribute with the knowledge. So how do we do that? And the way to do that is to bring these skills, the system skills and collaborative skills, to the master fellows, because we have among those fellows, we have veterinarian, we have agronomist, we have physician, we have social scientists in this master course. And by doing that, we are able now to put them as binom or trinom to work on a very key topic where each of them will look from its angle and see how to solve, for example, if we take the diabetes complex. So the question is, go to the community and bring back what intervention can we develop to control diabetes. So when you do that, you will see that it's not only a training in nutrition, which is important, but we need to have skills from social science, from economics, from the behavior change, and many other aspects that can contribute. So by doing that with the university, we have said, okay, that maintain their training, but we have to give them some competencies that will help them to collaborate and also to design intervention in the field. So this is what we brought on top of that.
That's excellent, Basaru. I think, you know, it's really interesting. You chose there a master's program that is inherently interdisciplinary, I suppose. And actually, it's great to see more acknowledgement of the One Health approach being really vital to sort of sustainable food systems and nutrition, because it's not something that was originally, you know, you've mentioned before, One Health, often we think zoonoses, and actually this broadening into sort of food systems as being a key One Health issue is really important. And I'll mention the Lancet One Health Commission. We have a section in that report on food systems and One Health. I'll pop the link in the chat later. So it's a really great example of where we can apply One Health, and having those multi sort of disciplinary groups of students working together is excellent. I can see how it might be a little more difficult in some of the master's programs which are a little more specific and you don't get such a mix of students. So I'm going to go to Shauna and just maybe ask a little bit about you've specifically been supporting the development of One Health master's programs, and maybe how that is different to what Basaru talked or similar to. So I'd love to hear a bit more about what you're doing there.
Yeah, actually, I would say it's very similar to what Basaru had mentioned, in that the development of the One Health Masters benchmarks was not to enact new master's programs, but to help universities that are already offering One Health degrees or want to think about how One Health can be integrated into their degree programs to have a more standardized way of doing so. So it's really meant for universities already offering One Health to look at the benchmarks and see where they meet those, where they don't, so that they can ensure that their graduates are going to have the competencies necessary to work within the One Health field, based on the fact that we consulted with people across the Eastern African and Southern African region to understand what competencies were essential, and are focused on these cross-cutting competencies so that it can really reflect any technical area of expertise.
Okay, that's really wonderful.
I just want to add something, saying sometimes some people ask me what is happening on One Health courses in Europe, for example. Why we are focusing on the training, the change of curricula or adaptation of the curricula in Africa. But I respond, I said, if a master course is developed to address a complex issue in a country, so this is where we need to bring One Health competencies, because it can improve things. It's not just to create a One Health and have a One Health degree, which is for us important. It's how this course can help those who are trained to go back and fix things together with others. So this is something which is very, very important. One Health is an approach. It's not an objective to reach. It's not an objective. It's an approach that we use whenever it's needed. And the experience showed that when we give all those competencies to our fellows, They don't use them. They just wait until a day where they have opportunity to mobilize the type of knowledge for that. So it's not systematic.
Great.
Over.
No, really, thanks, Basiru. It's really interesting. I mean, and thank you, Shauna, for that sort of indication that the benchmarks are there, accessible for people to, and for institutions to see, either within a One Health Masters or to apply a One Health framework for their other degrees, which fits into really well with what Basiru was indicating, that you've got these complex challenges, you've got people focusing on complex challenges, and you want to provide them with the how to apply a One Health approach. I mean, I mentioned at the beginning of the webinar that I wear another hat, which is as a lecturer at the University of Edinburgh, where we do have a One Health Masters program. It's been running for over 12 years now, and it is very much focused on sort of One Health principles, One Health approach, and with that sort of, if now very well articulated by OLEP, that sort of aim to sustainably balance and optimize the health of animals, humans, and ecosystems. So I think we have different ways of implementing it, either as a whole master's program or embedded across other more specialized master's programs. And it's really interesting to see the different models. So I see we've got just 10 minutes left, and I know there's at least one person from the audience who would like to ask some questions. So I'm going to open to the audience, and then we might just come back for one final reflection. So I will pass to my colleague Nicholas, and he can help us by telling us who's the first question, please.
Yes, so we have an hand from Shamsuddin. I guess you can go fast, but then there are two questions. I'll just post them so that the panelists can already start thinking about them. One was specifically addressed to you, Lian, but seems to be in general. And the question is, could you please share with us real-time experiences that demonstrate the engagement of humans, public health, and environmental experts in your One Health achievements in Africa? I guess the three of you can contribute to that. And then the other one is, I would like to ask if there are any upcoming training sessions or short courses in One Health designed for PhD holders to enhance their professional skills. That's from Wigdan. So I guess Shamtin can go first, and then the panelists can respond to those two questions. Over. Shams, you are muted.
No, thank you. Thank you so much. I don't know if the video need to, but anyhow, my name is Mohammed Shamsuddin. I was so happy to stand in the advisory committee of OHRECA on behalf of the FAO director. I work in the FAO regional office for Africa as a senior animal production and health officer, and also for an One Health focal point. I really enjoyed the discussion, and just wanted to reflect quickly what Basiru was building, and also, sorry, I skipped the name. I'm very bad in the lady who presented was on the master's degree. As we all know, I mean, university has their autonomy, respecting that. I mean, the master's degree, some master's degree will be good to have to provide the leadership. But having said that, we need more of a mindset of the graduates who will be actually leading the 3 or 4 sectors. And if the university, I will be quick because I want to also listen, if the university could have optional courses on One Health, which, you know, with the course credit system, the student can pick 1 or more courses there, to have additional skill as well as the awareness. I think those people will be more effective breaking these silos and working and joining in collaboration. The second point I would like to make, like as of today, 2 professional degrees, let's say I'm a veterinarian, so the PBS is still very, I mean, they have modified a little bit, but it has scope to have more focus on the competence, where are the One Health competences, let's say in the veterinary medicine, and similarly, where are more opportunity for One Health competence in the medical education when we are doing the joint external evaluation. The other point I would like to make is, when it comes to the environment, if we see the graduates who are leading the public sector, mostly coming from a forestry or zoology background, and this is where we need more communication for the forestry, understanding that there is a part of the health which where the veterinary and the public health needs an interaction. They don't need to take the job, but a platform to really to share. And similarly, for, let's say, as I see that there are good number of vets there or animal health scientists. Is still, I mean, we had very little exposure on other than disease diagnosis, treatment, and a little bit of the public health, veterinary medicine, and maybe an extra on the food safety and food. So that's why I wanted to just, it's not a really question, to add my appreciation and also share my views that education, we need to have it. It's the strongest, but I'm in favor of keeping more options. Let's put it in a way. Thank you so much.
Thank you so much, Shamsuddin, for your intervention there, your reflections, and for your work as an advisory member for OHRECA. It's been a real pleasure to have you as part of this project. Shauna, you'd like to respond on Shamsuddin's comments there. Thank you.
Sure. So I think in terms of when you mentioned the PVS and the JEE, the workforce development operational tool that's developed by the quadripartite helps address a lot of those competency gaps for everybody who's working in One Health. So all the quadripartite members, so all the different kind of sectors that would contribute to One Health, having this workforce development operational tool, which has many different components and stages, is quite helpful for countries to be able to address those gaps. And the tool is based off of addressing specific One Health competencies. They did an extensive review to have grouping of different competencies so that it could meet the different needs, and they're mostly cross-cutting competencies. So I'd say that's one really good thing that's being worked on to address those challenges. In terms of, you had mentioned teaching and having the ability of students to do things together. I think we can't expect students to go out and work with other people if we teach them in silos in higher education institutes. How are you you're not emulating real life by having everybody just, if you learn One Health as a vet, if you learn One Health as a medic, if you learn One Health as an environmental scientist. And I think this is what's unique about thinking about integrating One Health education at primary and secondary levels, because you have one teacher who's teaching all of those things. And so it's very easy for them to then, once they're trained on One Health, to think about how they can integrate that all together in their classroom. But we need to do a better job in faculty settings in higher education to come up with innovative ways to work with other faculties and have these scenarios where students can be together, learning together and acquiring those cross-cutting competencies. So it takes some innovation and time, but it's worth it, I think, for these faculty members to do that. So I'll leave it there as my thoughts and reflections.
A really great thought there, Shauna, on why we have the most impact if we can get in early with that sort of before people split into their silos. Though at university level, luckily, most of the universities do have a broad range of courses. So there we have to work hard to break our academic silos again and sort of emulate what we want students to pick up. Thanks so much for that. I noticed, I'm sorry, that we've gone on a long time. Nicholas, are there any other key questions from the chat? Otherwise, I'm going to just ask Basiru and Shauna to give a last reflection on the next step. You know, if we want to be innovative, what are the next things that we need to be focusing on?
Yeah,
So Nicholas?
I think we can have that round. Most of them
Okay.
have been captured in a way.
They've been captured in the chat. Okay, that's wonderful. Thank you. So first to Basaru and then to Shauna. We know that we need to be innovative. If we want to build One Health capacities, what's the key thing that we should be investing in over, say, the next 5 years if we're going to achieve the impact that we want to in this space?
Yeah, thank you very much. Three things. First is to raise the capacity of the environmental sector in the health aspect, because when we look at the work, the One Health implementation, this is where we have the gap, not only the knowledge gap, but also resource gap to really fill the problems, because if we want to prevent, it starts from the environment. So we need to equip them with health skills. The second is One Health, as I said, is an approach. He said we need to learn the diplomacy, how to bring people together, to work together, coordinate activities and leadership. And the third thing is that whatever we do is for, at the end, communities. And for us now, we are pushing to have community health workers. We don't even call them now community health workers. We have community agent who can be the ambassador of whatever knowledge is coming from the environment, the veterinary sector, or the public health sector, so that they can address that locally. Those are the one that all sector will come and address the issues. As Shona said, is the example of the teachers also. They are they teach everything, but at the end, the communities, they receive all of us. So we need to look at that point. Thank you.
Brilliant. Thanks so much, Basaru. I thoroughly agree. We've got to keep the communities in mind. Shauna, across to you for your last reflection, and then I'll finalize this session.
Sure, I'll try to be quick. I really think the main thing that we can do is work to integrate cross-cutting competencies that everybody needs to work in One Health into whatever curriculums that we're working on, no matter what the level of education. And I think that really means those of us who are teaching really need to reflect and think about how we're doing our teaching, not just what we're teaching, but how we're doing it in order to integrate these cross-cutting competencies. So that's going to mean educating these teachers about some of these new skills that they can use to integrate these cross-cutting competencies and greater enhance the ability of people to work with each other and not by themselves. Thanks.
Yeah. No, thank you so much, Shauna. I think, yeah, the skills of how to teach, it's so vital, and actually that. Yeah, and we've got so many opportunities. I think we've got so many opportunities through new technology, new innovation, the realization that all of our challenges, even if we're thinking outside of One Health, our challenges are complex, and the cross-cutting skills are so important. Well, I thank you so much, firstly, to my panelists, to Basaru Bonfo and to Shauna Richards, for your time today. It's been really, really great to talk to you about, well, first hear what the projects have been doing. It's been wonderful to be able to share with each other what we've all been doing in this space, and to have this really interesting chat. Thank you to everyone who's attended. If there are any questions outstanding that we haven't had a time to get to, please just pop them in an email. Jeffrey can just pop the OHRECA email in the chat, and we can follow those up. You will receive a link to the recording. It will be on our YouTube channel, and Jeffrey's also shared a link to our next webinar. I'd also like to take this opportunity to thank all of those in the OHRECA project that we're sort of celebrating the end of this project through this webinar series. So thank you to all my colleagues. Thank you very much to all of our advisory committee members. We've seen several of you in here today. Obviously, we have Basaru and our on our panel. We've had Shamshuddin come and give us some reflections. We've also heard in the chat from Gladys, and I've seen Dieter Schillinger in the chat as well. So it's been brilliant to see our AC members here. Thank you to our Deputy Director General Bonnie, who's been able to attend. So thank you so much for your time. Thank you everybody for coming. I hope to see you at our next webinar, which is on climate and health on the November the 7th. So we're wrapping these webinars around the upcoming One Health on the 3rd of November. So let us keep thinking about One Health, how we can implement it in its different guises. Thanks everyone for their time, and we will see you at the next session. Goodbye.
Thanks.
Bye.
Bye, everyone.